Hello dear friends, today's our topic is arrhythmias. Let's start from the classification of arrhythmias. We are recognizing three types: impulse formation disorders, conduction disorders, and combined arrhythmias. For impulse formation disorders belongs two groups: nomotopic rhythm disturbances and heterotopic rhythm disturbances. For nomotopic rhythm character belongs sinus arrhythmia, sinus bradycardia, sinus tachycardia, and pacemaker migration. For heterotopic types of disturbances belongs extrasystoles or premature beats, paroxysmal tachycardias, and both of them, premature beats and tachycardias, they have two types, supra and intraventricular. And next is atrial flutter and fibrillation and ventricular flutter and fibrillations. For conduction disorders belongs all blockages like SYNOATRIAL blocks, INTRA-ATRIAL blocks, AV, and intraventricular blocks. And combined arrhythmias, there are sick sinus syndrome, AV dissociation, and pre-excitation syndrome. There is reasons of etiology factors of arrhythmias. All heart disorders which result in injury of myocardium may cause developing of arrhythmias like ischemic heart disease, valvular heart disease, arterial hypertension, myocarditis, and cardiomyopathies, heart surgery, genetically determined anomalies of conductive system. And also arrhythmias may develop because of dysfunction of central nervous system, endocrine diseases, electrolyte imbalances, mechanical and electrical injuries, hypo and hyperthermias, excessive physical activity, intoxication with alcohol, nicotine, coffees, and drugs, diagnostic manipulations. Let's start from the sinus tachycardia, bradycardia, and arrhythmias. Sinus tachycardia it may present even in normal patient, for example during doing exercises or during being under emotional heaviness, and you see how you can recognize. You can recognize on ECG by increasing of heart rate up to 90 to 160 per minute and maintaining the correct sinus rhythm. You see here on the first picture, you see normal rhythm, and then during tachycardia you have shortening of, you could see shortening of RR intervals. Sinus tachycardia may develop in hyperthyroidism, for example in pheochromocytoma, and in hypovolemia conditions also. Next is bradycardia, sinus bradycardia, decreasing heart rate below 60 per minute, and also here is maintain the sinus rhythm. You see sinus P before QRS complexes, only we have elongation of RR intervals, and it may character for normal healthy patient during sleeping time, or if your patient is athlete. For pathological condition also may character in case of hypothyroidism or decreasing hypothyroidism, or developing of, for example, cholemia syndrome may develop this sinus bradycardia. And next is sinus arrhythmia. Here is present a sinus respiratory arrhythmia. You see a fluctuation on RR intervals exceeding 10% and associated with breathing phases. During inspiration you have shortening of RR intervals, during expiratory phase prolongation of RR intervals, but maintaining the correct sinus rhythm P wave before QRS complexes. These respiratory arrhythmia, sinus arrhythmia, may belongs to respiratory disorder sometimes, or sometimes may occur in patient in young patient, and may be character for teenagers. You see again, this is normal rhythm. Here is sinus tachycardia, here is sinus bradycardia, and sinus arrhythmias. Next is premature beats. Premature beats or extrasystole is a premature excitation of whole heart or any of its parts caused by extraordinary impulse emanating from the atria, AV junction, or ventricles. There are the following types of premature beating: functional, or organic, or toxic. Under developing of premature beating lies re-entry mechanism. You see, with the development of electrical inhomogeneity, a difference is formed in the speed of the impulse in different parts of myocardium, and this cause this area is excited in a roundabout or wrong way. The rest of heart muscle already leave the state of refractoriness by this time, and they are again excited, and you see again excitation, going off excitations. What the general signs, ECG signs of premature beating: premature occurrence of ventricular QRST or P wave, you see premature occurrence, and also you can distinguish there are two intervals and pause. First is coupling interval. You see here is coupling interval between this PP. You see coupling interval is a distance from the preceding premature beating of the next P. You see premature beating, preceding premature beating, and next P QRST cycle of main rhythm to the premature beating. Compensatory pause. You see next is compensatory pause, the distance from the extrasystole to the following P QRST cycle of the main rhythm. We have two types of compensatory pause: incomplete and complete. Incomplete compensatory pause is a pause that occurs after atrial premature beating or premature beating from the AV junction, the duration of which is slightly longer than usual PP or RR interval of the main rhythm. An incomplete compensatory pause includes the time required for the ectopic impulse to reach the sinoatrial node and discharge it, as well as the time it takes to prepare the next sinus impulse in it. Full compensatory pause, a pause you see, for example, on first is incomplete, and the second picture full compensatory pause, a pause that occurs after ventricular premature beating, for example, and the distance between the two sinus complexes PQRST. There is two sinus, you can line of two sinus complexes PQRST pre-extrasystolic and post-extrasystolic is equal to twice the RR intervals of the main rhythm. Incomplete and complete. And let's start from the atrial extrasystoles or premature atrial contraction. Is a premature excitation of heart under the influence of an extraordinary impulse from the atria. ECG signs: premature extraordinary appearance of P wave and the following QRST complex. You see deformation or change in the polarity of P wave of the extrasystole. You see here deformation. If you compare with the normal P, you see here deformation of P. Presence of an unchanged extrasystolic ventricular QRST complex. You see extrasystolic ventricular complex, same with the normal complex, and presence of an incomplete compensatory phase. This is signs of premature atrial contraction. Next is AV bundle premature contraction. ECG signs for AV, ectopic foci located in AV. That's why we don't have here excitation of P wave or excitation of atriums. Here is premature extraordinary appearance of the ECG of an unchanged ventricular QRS complex, similar with the normal complexes. Negative P wave or sometimes negative P wave in these 3, second, third, and AVF after extrasystolic QRS complex, or absence of P wave due to the fusion of P and QRS and presence of an incomplete compensatory pause. On this picture you see real AV bundle premature contraction. You see normal, which interrupt normal beating interrupted by premature beating, premature contraction, and there is no P wave, but after extrasystolic complex you see incomplete compensatory pause. Next is premature ventricular contraction. Ventricular contraction is a premature excitation of the heart which occurs under the influence of impulses arising from various parts of ventricular conduction system. For example, it may be located in right ventricle or left ventricle. And ECG signs of primitive ventricular contraction. There are primitive appearance of altered ventricular QRS complex on ECG. You see here is different primitive complex and also QRS complex, which is different from normal QRS complexes. You see significant expansion of QRS complex and deformation of the extrasystolic QRS complex. Location of the RST segment and the T wave of the extrasystole is discordant to the main direction of QRS complex, and absence of P wave before primitive complexes. There is no P wave. Here is T wave, P, QRST, and just after T appear deformed QRS complex, and presence of complete compensatory pulse after this extrasystole. And here you see there are three types again. Primitive atrial contraction. You see in atrial contraction there is normal PQRST, but only we have here appearance in refractory phase, and after them has incomplete compensatory pulse. In bundle primitive, there is no P wave. Here's only QRS complexes, and QRS complex similar with the normal, but we have also incomplete compensatory phase. In primitive ventricular, we have enlarged deformative QRS complex, only QRS without P with the full compensatory phase. Next topic is paroxysmal supraventricular tachycardias. We have tachycardias. We divided into two types: supraventricular tachycardias and ventricular tachycardias. Paroxysmal tachycardia is a sudden onset and just a suddenly ending attack of increased heart rate up to 140 to 150 per minute while maintaining the correct regular rhythm in most cases. Often people have no symptoms. Otherwise, symptoms may include palpitations, feeling lightheaded, sweating, shortness of breath, and chest pain. There are two types of supraventricular tachycardia: atrial tachycardia and junctional tachycardia, or AV nodal tachycardia. Atrial tachycardia are suddenly characterized by suddenly beginning and just as suddenly ending attack of increased heart rate up to 140 to 250 beats per minute while maintaining the correct rhythm. In front of each ventricular complexes, QRS complexes, there is a reduced, deformed, or biphasic P, and also QRS complex is narrow. The P wave is not of sinus origin, therefore its amplitude, shape, and even polarity can be changed, but it is. Junctional tachycardia characterized by suddenly beginning and just as suddenly ending attack also, but heart rate is 140 to 220 beats. The presence in lead, second, third, and EVF or negative P wave located behind the QRS complexes or merging with them, and not recorded in the ECG sometimes. Normal if the re-entry loop is located in AV node. Normal unchanged, not broad ventricular QRS complex similar to the QRS, normal QRS, registered before the onset of paroxysmal tachycardia attack. Here is atrial tachycardia. For example, you see here atrial tachycardia. Next is atrial fibrillation and flutters. Atrial fibrillation and flutters are two closely related cardiac arrhythmias in the mechanism of their occurrence, which often transform into each other in the same patient. In terms of the prevalence and frequency occurrence, atrial fibrillation is second only to extrasystoles, ranking first among arrhythmias requiring hospitalization and treatment in a hospital setting. Atrial fibrillation is a condition in which there is a frequent up to 400 to 700 per minute erratic, chaotic excitation and contraction of certain group of atrial muscle fibers. Atrial flutter, excitation and contraction also with a high frequency, it's about 300 per minute, but the correct atrial rhythm is usually maintained. In both cases, The AV node cannot pass such a large number of atrial impulses to the ventricles. Since some of them reach the AV node, then it is in a state of refractoriness. That's why on ECG in atrial fibrillation, for example, here is atrial flutter on the second picture. This is atrial fibrillation. On the here you see also atrial fibrillation. On ECG, you see P wave is absent. You see there is no P wave, and instead of P wave, you see multiple oscillating baseline waves, small f waves, and with the various amplitude and shape. And you see RR intervals, various RR intervals, irregular ventricular rhythm, and QRS complexes are not changed. In case of flutter, atrial flutter, the presence of ECG of frequent up to 200 to 400 per minute, regular similar atrial waves, you see similar atrial waves, with a characteristic sawtooth shape. In most cases, the correct regular ventricular rhythm remain at the same FF, you see FF intervals, except for cases of change in the degree of atrioventricular block at the time of ECG registration, and presence of normal, unchanged, narrow ventricular complexes, each of which is precedes by a certain number of atrial waves, you see. Next is ventricular tachycardia. Ventricular tachycardia, in most cases, it's a sudden and just as suddenly ending attack of increased ventricular contraction up to 140 to 180 beats per minute, and less often more than 200 beats per minute or within 100 to 120 beats per minute, usually while maintaining the correct regular heart rate. ECG signs you see of ventricular tachycardia is suddenly starting and just a suddenly ending attack with a high frequency, deformation and expansion of QRS complexes more than 0.12 second, and also discordant location of the ST segment and the T wave. You see ST segment and T wave discordancy, and the presence of AV dissociation is a complete separation of the frequent ventricular rhythm and the normal sinus rhythm of the atrium. P wave dissociation of P wave and QRS complexes. You see here is a full dissociation of P wave and QRS complexes. And arrhythmia, ventricular tachycardia, occurs predominantly in patients with serious organic heart disease. Also, a few seconds may not result in problems. Longer periods are dangerous. Short period may occur without symptoms or present with lightheadedness, palpitation, or chest pain. And ventricular tachycardia may result in ventricular fibrillation and turn into the sudden death. Ventricular flutter and fibrillation. The main ECG signs of these severe cardiac arrhythmias are with ventricular flutter, you see frequent up to 200 to 300 per minute, regular and identical in shape and amplitude flutter waves resembling a sinusoidal curve. Fibrillation of the ventricles is frequent up to 200 to 500 per minute, but irregular random waves that differ from each other in different shapes and amplitudes. And quickly, these two conditions may result in fully asystole phase. Here is again flutter and fibrillation of ventricles. In these cases, of course, our patient will lose the consciousness. Why? Because when this our cardiac muscle contracted in speed of 200 to 500 per minute, of course, who couldn't pump entire blood, of course, will be extremely decreased blood pressure. Next is blockages, SYNOATRIAL blockages. SYNOATRIAL blockages is characterized by slowing down and periodically onset cessation of the propagation of individual impulses produced by the sinus node to the atria. Conduction disorders is localized in the region of the sinus atrial junction in the border zone between the sinoatrial node and the atrial myocardium. ECG signs of SINOATRIAL blockages are sinus rhythm, you see P, QRST, sinus rhythm, but irregular, occasionally emaciated cardiac circle, P waves and QRS complexes drop out, you see here is normal, and again here is drop out one PQRST complex. Elongated PR interval during pauses blocking the impulses are equal or slightly shorter in duration than 2 PR intervals. After long pause, the PP interval is gradually shortened, and during long pauses, slow escaping complexes and rhythm may appear. You see here is dropping of one PQRST complex. Intra-atrial blockages or atrial blockages is a violation of the conduction of an electrical impulse through the atrial conduction system, and on ECG we recognize two blockages, 2 degrees. First degree when you see constant and each cardiac cycle increasing duration of P wave in the limb leads more than 0.11, you see elongation of P, and cleavage or jugment of the P wave, intermittent sign. And second degree of blockages are characterized by gradual increasing of duration of and cleavage of P wave in the limb leads, and periodic disappearance of left atrial phase of the P wave in first lead V1. AV blockages. AV blockages is a violation of conduction of the electrical impulse from the atria to the ventricle. We distinguish 3 degrees. First degree characterized by a slowdown in conduction in AV node. Second degree is gradual or sudden deterioration of conduction with periodically occurring complete blockages of 1, less often 2, 3 electrical impulses. And third degree, this is complete blockages, complete cessation of AV conduction. Let's start from first degree. To ECG character an increase in duration of PQ interval, mainly due to the PQ segment, you see duration of PQ interval, and normal duration of P wave and QRS complexes. This is AV blockages first degree, just we see elongation of PQ interval. Next is second degree. General characteristics, the sinus rhythm remains, but in most cases it's incorrect, and periodically the conduction of individual electrical impulses from the atria to the ventricles is completely blocked. There is no QRST complex after the P wave. And AV blockages we have 2 types, Mobitz 1 and Mobitz 2. For Mobitz 1, character gradual from the complex to another, increasing duration of PQ intervals, which is interrupted by the prolapse of the ventricular QRS complex. After the loss of QRS complex, normal or slightly lengthened PQ interval is again recorded, then everything repeats. You see here we have shorter, longer than PQ or QRST. You see here PQ interval, long PQ interval, again elongation of PQ interval, and then we have P wave and absent, dropping of QRST, then again shorter, then longer, and drop in one side. Mobitz 2 characterized by regular or disorderly loss of QRST complex while maintaining the P wave, and presence of a constant normal or lengthened PQ interval without its progressive lengthening. You see here long QRS or PQ interval, PQ interval, long again, and this is distance PQ of interval, the same distance, but we have dropping of each second or third QRST complex. And next is AV blockages third degree. This is complete blockages, complete separation of atrial and ventricular rhythm or atrioventricular dissociation, and characterized by regular ventricular rhythm. You see here is our atriums, they contract from sinus node. Our ventricles contract from AV node. You see sinus node may produce impulses from 60 to 80 impulses per minute, whereas ventricular complexes they could produce only 40 to maximum 50. That's why you see complete dissociation of ventricles and atriums. They have own rhythm. You see, if you compare PP, if you count heart rate between the PP, it will be about 60 to 80. If you count heart rate by ventricular complexes, QRST between the RR, it will be about 40 to maximum 50. It will be. Also, this atrioventricular blockage, third degree, may complicated by Morgan-G-Adams-Stokes syndrome, is a pronounced hemodynamic disorder due to a decrease in cardiac output and hypoxia organ, primarily the brain. Especially dangerous in this respect a long period of ventricular asystole, periods of absence of effective ventricular contraction resulting from the transition of second-degree AV block to complete AV block, and without treatment it may result in death. And again you see AV block first stage we have only elongation of PQ interval. Second degree Morbitz 1 we have gradual elongation of PQ with a dropping of QRS complex. Second degree Morbitz 2 you see constant elongation of PQ but dropping each second or third QRS complexes. And AV block third degree, this is complete dissociation of ventricles and atriums. Atriums, they have his own rhythm. Ventricles have own rhythm. Next is bundle branch blockages. We are recognizing two types, right bundle branch blockages and left bundle branch blockages. Let's start from right bundle branch blockages. On ECG, right bundle branch blockages appear by the presence of the right chest leads, V1, V2, you see, less often in the leads from the extremities, third and AV, of the QRS complex of RSR, you see, small RSR, RSR type, having an M-shape appearance, you see, M-shape appearance, and V1 and V2, and presence of widened, often serrated S-wave in the left chest leads V5 and V6, and the leads first and AVL. The increase in duration of QRS complex is more than 0.12, you see, of course, and depression of the ST segment and negative or biphasic asymmetric T wave in lead V1, less often in lead 3. And because of right bundle branch blockages, impulse couldn't pass through this right bundle branch, and we have excitation of right ventricle occur by left side, by generating of impulses from left side. That's why we have elongation of QRS complex, because excitation of right side takes time. Next, left bundle branch blockages. You have blockages of left side, of course, and left ventricle excitation occur from the right side, and also it takes time. And we have on ECG see presence of in lead V5, V6, widened deformed R with a split or wide apex, presence in lead V1, V2, third and AVF leads, widening deformed S-wave, you see, SQS complex with a split or wide apex, you see, increase in total duration of QRS complex to 0.12, the presence of in lead V5, V6, first AVL discordant in relation to QRS displacement of ST segmented negative or biphasic asymmetrical T wave, and a deviation of the electrical axis of the heart to the left side sometimes. And on this picture you see right bundle branch blockages, you see M shape on the V1, and left bundle branch, complete left bundle branch blockages, you see elongation of QRS complex, and also S, deep S, and S on right side. And this prolongation of QRS complex, of course, more than 0.12. Thank you for your attentions.